I'm going to go over a couple different topics today. If this is the lumbar spine model, the thing I'll be talking about a lot, and same with the cervical spine, it goes bone, disc, bone, and you have these facet joints in the back. The reason different people get pain is either from a pinched nerve, that's numbness and tingling. You can get it from the joints rubbing, the facets, something like this spine model here. There's an acrylic model on the back that these joints were rubbing. That can give you some spine pain. And there's different treatment options. One of the questions I see from Kelly Atkins, she's asking about the back doctor that wants to do SI injections. I'm okay with that. Look, SI joint pain is a difficult thing to diagnose. One of it's a clinical diagnosis. There's different tests that you can be pushing on the hips, the pelvis to see. But the other diagnosis is an SI joint injection. The biggest thing that I counsel patients on is if you are going to get any type of spine surgery, whether it's something called the MILD, mild procedure, or an SI joint fusion, I just really counsel patients to have a spine surgeon do those. Yes, I'm a spine surgeon, so that's obviously biased of me to say that, but if you're at home thinking this, it just kind of makes sense. A spine surgeon should do spine surgery. A spine surgeon should just focus on what they're good at, and a pain doctor should focus on what they're good at. There's many spine surgeons there's tons that do SI joint fusions. There's tons of spine surgeons that do the mild procedure. I just don't like it when I'm seeing patients that have tried for years and years to avoid bigger surgeries. They go through these things with these other providers, and then they actually don't get the care they need. So that's the only thing that bothers me sometimes about non-spine surgeons doing spine surgery. Question from Denis Delver. Can I have a disc replacement? The rest of the comment went away. After a fusion. You can get the level above. So if, it's kind of a fusion model here. So if you get a fusion at one level, you can get a disc replacement, which is this right here, at another level. And I'll go over some of these models. I can show these in more detail. Here's a disc replacement. This is a one level. Actually, it's part of a two level. So look at that. So if I do it just like that, it's better when I have the stand. That's a two level lumbar disc replacement. Sometimes I like to take that off, and then it's just easier. And a one-level disc replacement. I have mixed thoughts on lumbar disc replacements, for the record, but I love cervical disc replacements. This is a giant model of a cervical disc replacement. They're much smaller. I'm trying to reach behind me to show you. Here's a model, actual size, of a cervical disc replacement, just like that. I use three different ones. I like Pro Disc, I like Mobi-C, I like Simplify, but there's others out there that other people use. It's a little bit of preference, and it's a little bit about the anatomy kind of when you're in there looking at it. Going to jump to some other things. Titanium mesh usage. I know that the titanium stuff from Spinology, I do like those. I don't know if that's that titanium mesh you're talking about. Kind of getting to that question I just saw. From Johnny McClellan, I have lumbar stenosis for 2 years. Do you have to go through all the therapy and shots before insurance will approve it? Not always, Joni. Joni, usually there's three things someone has to do to get insurance to approve a surgery. One, it could be if your Medicare, certain codes or certain procedures don't need prior authorization, and that's kind of great for the patient. God knows how much you, me, have paid to the Medicare already. And so it's nice that if you need something, it can get done. Now, that's not always true. If you have a supplemental or replacement plan, that still has to get approved. But that's kind of one avenue. Two, for the commercial insurances, I think most of them still have to get approved. Some of them get automatically approved. But the things you do have to do is they like to see 6 weeks of conservative care. Now, it really is crazy because does that mean injections, or does that mean physical therapy, or does that mean both? I've 100% had patients from Aetna and Cigna where they've had multiple injections, but I get this peer-to-peer, and I'm going to tell you some peer-to-peer stories here in a minute, where they call me and they say, oh, they haven't done physical therapy. I'm like, well, they've done physical therapy in the past. It was just months and months and months ago, or it was 2 years ago, but they're on injections now. They're like, well, they need to do physical therapy again. So I personally consider injections a form of conservative care. So to make the patient also have to go to physical therapy in addition to injections, in addition to medications, is crazy, but that's really what some of them make you do. And then the third thing is if you have profound weakness or risk of loss of motor function, then that's another way you could skip those prerequisites. So I hope that kind of answers your questions. Does Medicare Plus tend to pay? I don't know what Medicare Plus is. I apologize. Does Medicare Plus tend to pay easier versus work insurance? Johnny, I don't know what that means. I'm sorry. I don't know what Medicare Plus is. I know what Medicare is. I know what supplements are. Next question from Raj. I've gone through spine fusion surgery TLIF 6 months ago. So can I bend forward? I mean, flexion, exercise, and standing. Also experiencing pain when I sleep. You just have to ask your surgeon. In general, when I do a TLIF surgery, I don't love doing TLIFs at 5'1". I like doing A-lifts at 5'1", but different argument. Not everyone has the same approach, surgeons, to do 5'1" surgery from an anterior approach. But I let my patients go back to bending, twisting after 6 weeks. So I would just ask your doctor, now that you're 6 months out, is a good bed a contributing factor? We don't really know. Hard bed, soft bed, they're all good. We don't really know. Appreciate all the likes coming in. Keep crushing those. The only reason I care, I'm not trying to get famous on this, but I think it would help promote this to your peers going through similar things. It might prop up on their chat, and it goes from there. Do I work with the VA? I work with different veteran insurances, but I'm not a VA employee. I worked for the VA indirectly through residency for 5 years in Miami, Florida, and it was a great time. It's one of our favorite patients. How do you feel about Botox for spine pain fractures? Oh, I don't even begin to know what that means. I'm okay for Botox for muscle contractions, particularly in the cervical spine, but for like fractures, not, I don't know. That just seems like a very intense treatment for something that I don't know. I don't love that idea, as we can tell. Laura Perkins, can you talk about a T10 to pelvic surgery? I can, Laura. Look, you hear all the time that, oh, spine surgery is terrible, spine surgery is bad. T10 to pelvis is a bad surgery that's painful for the patient, but extraordinarily rewarding once you get past the recovery process. So if it's a 1-level fusion, 2-level fusion, people bounce back really fast. Some 1-level fusions, you might even go home that day from surgery. A T10 to pelvis is one of the larger elective spine surgeries we do. It's essentially indicated for a degenerative adult scoliosis, spinal imbalance issues. It's a big incision about this, trying to give you some context. If this is a writing pin, it's about 3 of these writing pins, so big incision. And it's rods and screws at many levels, T10, T11, T12, L1, 2, 3, 4, 5, and then all the way S1 pelvis. The reason someone would be indicated for that is if they have severe degenerative scoliosis, arthritis throughout the entire lumbar spine, and they have something called pelvic imbalance. It's a big surgery. It's tough, and those are the surgeries that have big complication rates. Unfortunately, those are also the surgeries that scare a lot of younger people that don't have a big issue away from spine surgery. They're so afraid of, people that have that surgery and get into chats and say, oh, how terrible it was. And like, I agree. It's a terrible surgery. It's a hard surgery. Surgeons don't always love having to do that surgery, but if you need it, you need it. And fortunately for you, we do have the tools to do it. So it's a tough surgery. It's a tough recovery. That's really about a 6-month, even a full year recovery from a lot of my patients, versus a 1-level fusion, a 2-level fusion. Those could be back at work in a couple weeks, back to running, jogging, a couple months. So I'm actually working on a video right now on my phone, kind of talking about my spine surgery recovery. It just takes a long time to make those videos when you have a family and an active practice. So working on that, and I hope to post that later. From Chrissy, I've always had pain in the neck. Can I get relief? I hope so. I'm not sure what's causing it. From John, how do your disc become disconnected? I'm not exactly sure what that means. I might be spondylolisthesis slipping forward. I just don't know what that means. Hi, from Mary. Good to see you. Carol, thanks for the follow. Good to see you. Thanks for that. Hi from New Hampshire. Hi from Venezuela. Good to see you guys. From Mandy, very similar views and techniques as our neurosurgeon in our busy hiring practice. Oh, that's great. I'm in Dallas. I'm not interested in moving or leaving. This is where I was born, where my family's from, where my wife's family from, where my kids are born. So Dallas is home. I'm probably never leaving just because grandparents from here, parents from here, and born here. So I'm very Dallas through and through, and never going to leave even if it gets really hot. Although this wasn't that hot of a summer. Not over yet, but not that bad. From For Fun, C3 to C6 fuse, ? Not sure what that means. Yes, you can. Sometimes I read these comments fast and don't exactly read them all out. From Itari, yep, it's one of my kids' names. It's true. You seem to be a big-time follower there, and I appreciate it. Hello from Norway. Can you explain a TLIF surgery? I'd love to. A TLIF is probably one of the more common fusions we do. Now, look, when you say fusion, pretty much we just mean those two bones getting mended together. In almost all cases, we're using screws in the back. Okay, so that's the posterior instrumentation in the back. Now, modern spine surgery over the last 20 years, but really improving even the last 15, 10 years, we now have an understanding that it's great, not always, but in most cases, if you put a spacer in this disc space, that can be something like this. This is a A-lift cage, an A-lift cage. Here's another type of A-lift cage. I have a T-lift cage right over here. The advantages of those cages, they open up the nerve tunnels in the back. So check this out from Norway. I hope you're following this. See how these nerve tunnels are here? And you have this bone over the top of it? Well, you can imagine if you got a lot of arthritis or lost your disc space, it'd come down and pinch that nerve. Well, what's great about the spacers, they do three things. One, they improve the fusion. Instead of just having this worn out disc, they improve the fusion. Two, they open these nerve tunnels. You know, you can imagine pulling this open. And then three, they curve you back. They give you that lordosis. A T-lift is when you do it all from the back. You push the nerves to the side aggressively, and you do it all from the back. For instance, these are two different types of T-lift cages. This is a banana T-lift cage. So it goes in, you kind of curve it around. This is a pliff cage. Someone could use it as a T-lift cage, but to be fair, I'll use this. So like here are three different cages. Look, these are pretty high-tech cages. See how they're like mesh, they're webbed. Well, the cool thing about this, these are some 3D printed technologies. I like these because you pack the patient's bone in here and the bone graft in here. It's like this nice, cool lattice structure. Pretty high-tech stuff. These are three different cages, and they go in from three different ways. This goes in from the back, and it's cute. Look how tiny, small that cage is. Tiny, itty-bitty cage. You might be like, oh, that's good. I like small cages. Not sure about that. The advantage of the bigger cages is you get more surface area over the bone, so that's less bone kind of subsiding through. You can get more correction, more height improvement. You can get more surface area, more fusion surface area. And if you're looking at these, so let's put this is a lateral cage. It's hard for me to hold three cages at once. So like if you're comparing these two cages, it's a no-brainer. This cage is bigger, right? This cage can't go in from the back. This is giant. This is huge. You can't get this from the back part of the spine. So back in the day, someone found out that you can actually make a small incision under the belly button, go through the belly. You just push all the guts to the side, and then at 5'1", the vessels split, kind of just like that, like a goalpost. It gives you this area here. And you can put this fatty sucker there, which is great. Gives you more height, gives you more curvature, gives you more unloading. An anterior approach, here's another cage, and this has little bolts that go through this cage. This one's awesome. This is from another Dallas company. I like to use Dallas companies. I'm a Dallas guy, a whole different thing. I won't waste your time with that. But going through the front is fantastic. So many patients are afraid of it, and there's other doctors out there that are a little against it, but mainly they're biased. They don't have a vascular surgeon in their community, or they don't want to pay the vascular surgeon to come do that approach. But an anterior approach is a fantastic option if you have a good vascular surgeon. Fortunately, I legitimately think I have two of the best in the entire world. That's without a question. I think most would agree. People from Dallas watching this be like, I know exactly what you're talking about. But if you don't have a vascular surgeon, if there's different economic barriers, you might have to go through the back only. And then you have these T-lift cages, and that's great. We've had T-lift cages forever, but it's for sure shown in large data pools that the T-lift cages don't give you as much height restoration. They don't give you as much curvature back. Now, if you're one of the most famous spine surgeons in the world in Chicago, Illinois, you're probably going to do a T-lift better than I could do an A-lift. That's a fair statement. So I'm not saying everyone is equal and someone's T-lift can be better than my A-lift, but in general, the A-lifts give you so much height, so much restoration. And then I have this cage. This is a lateral cage. So I was showing this a minute ago. Lateral cage. This goes in under the ribs. I love lateral cages. You just can't do them at 5'1". You go through the side here, and it kind of pops it open. So this is great. You can see that footprint, huge footprint going across. So no really long answer, but I know you're asking all the way from Norway, and I hope that kind of really answered a lot of other questions people might have of why do we have these different approaches? Why not just everyone do it this way? Everyone do it from the back. Everyone do it from the side. Everyone do it from the front. And those are some of the factors. Those are some of the things to think about. All right, I'm going to kind of jump to a couple other questions here. Raj, good to see you, one of my longest time followers. Thanks so much for asking. I'm going to get to your question here, but let me kind of talk. So you're amazing. Tell me about revision surgery for disc replacement or fusion. Is it complex or difficult? A revision surgery for a disc replacement is a very complex case. A revision surgery for a fusion is not that complex. I see. Sorry, I misread your question. A revision surgery from a disc replacement to a fusion. Not that crazy. It depends. In the cervical spine, not that hard, not that crazy. In the lumbar spine, it's a big deal. So two different things. Try to get some of these questions here from Hope C. Thanks for the follows. Thanks for the shares. Appreciate the likes coming in. If we can get that to 10,000, that'll be great. Kind of promote this to your friends. I'll kind of focus on these questions right here for a little while. I know I've been ignoring them, so let me just do that. Is there a fix for facet bone pain from Alex? There is. Injections that identify it, then you can burn it. Can you explain SI joint fusion? Here's the if this is the pelvis, then you have, this is like the sacrum. You have these bones on the side here. That's the pelvis. First, you have a joint in the back here. It's a massive joint. The best way to know if an SI joint fusion will work is you get an injection there. If you get an injection or get relief, you could be a candidate for a fusion. Please make sure a spine surgeon does that if someone's going to do it, not a pain management doctor. I like pain management doctors. I think they're great, but I will kind of say I think spine surgeons should be the ones doing spine surgery. Getting some other questions from Mickey. I need a doc. I keep getting bounced and bounced. I'm scared. I don't know where to go. Hi, good to see you. Okay, Alex, I had nerve ablations. They're doing more damage than good. Sorry to hear that, Alex. There's some doctors out there, it's a growing field, that do something called endoscopic medial branch transection. So endoscopic medial branch transections. Those are for people that have back pain. You can prove it's one or two joints. You've had burning of the nerves, and then it comes back. I actually don't do that surgery. I will one day, but I just feel like I got so many other things going on. I don't want to kind of focus on that yet. My best friend in my group, if you want to write this name down, he's here in Dallas, Texas, named Augustus John Rush, AJ Rush. He does that. And the candidates that are best for it is back pain from joint arthritis that have had ablations, had RFAs, and those worked great until they didn't. So you have to have gotten relief and then not. And the only reason I kind of emphasize that is, look, if you're like, oh, those never helped, well, then maybe that's not the diagnosis. Maybe you shouldn't have this other procedure. Anyway, from Atticus, you're saying you're an Amarillo and you have cauda equina syndrome and you need a doctor. Well, my legal advice is you should go to the hospital right now. Cauda equina syndrome is a medical emergency, so you're in Amarillo, you should go to Amarillo or wherever the hospital is around there. So that's my advice. Thanks for telling me a couple of times. What part of Texas am I in, Claudia? Claudia, I'm in the same place I was born and raised, here in Dallas, Texas. I did leave for about 10 years to go train. I was in El Paso for a while. I was in Miami for a while. I was in Philadelphia for a while, kind of all over the country. Go from there. From Atticus, they sent me home. Okay, well, I can't really give a formal medical diagnosis over it. From Nick, hey, have you heard about ozone treatment? A little. If you want to direct message me about some ozone treatment, I'd love to read a little bit more about it. I'm not against it. I just don't want people paying a ton of their hard-earned cash for something that's not totally proven, so I'm okay with it. From Pepperoni, what do I think about chiropractics? I'm okay with chiropractic doctors. Don't love them, but they're okay. My son is a Zimmer rep in Dallas from Big Skillet. I might know him. Zimmer doesn't have a huge presence with where I'm at, but love for them to reach out. I'm sure they're great. From Canis, I had an L4 to S1 fusion 7 years ago and have degeneration. Can you talk about that? So I don't exactly know what the question is. So an L4 to S1 fusion would be these two bones getting fused. It'd be a total of 6 of these screws. These are some minimally invasive pedicle screws I use. And then maybe you have disc degeneration at L3 now, L3-4. Look, the argument I tell patients all the time, it's like if you got your hip replaced and your knee replaced with a joint replacement doctor, and now your ankle is going out, you're not going to, those people are never like, I should never have done my knee replacement and had those years of pain relief because now my ankle is going out. Well, no one ever says that because it's just another joint in your body that wears out. And people understand that for the ankle, but it's not always perfectly agreed upon for like the L3-4. And so I say, look, you've had the same wear and tear, the same genetics, the same beating down of the disc space of the nerves at all those levels. It was just that the doctor only wanted to treat 1 or 2 of the levels, and now your other level needs it. So I kind of like to tell patients that a lot. It's like, look, will you need another spine surgery? You have a lot of other joints in the spine. I could fix multiple levels, but let's just fix the 1, maybe 2 that you need. What's my background? I'm a spine surgeon here in Dallas, Texas. I'm in a how many is in our group? 5 people, and then on Tuesday, or maybe tomorrow, actually, maybe the 1st of the month, we're officially a 6-person spine surgery group. So we just hired another one of my buddies who is in the Dallas area, and that's kind of nice. So we're growing, which is great. It's kind of nice. You're already in the market. We're already colleagues. Let's just put on a different white coat and be on the same team. And, the more spine surgeons in a group, the better. More people we can bounce ideas off of, send text messages about cases. And, it's nice. Being on your own is tough. Being maybe the only doctor in a hospital system is tough. You don't really get to have the camaraderie or have questions or, have everyone check your work. It's kind of nice to be held accountable. I have an extra level of like, hey, if one of my buddies comes in here and sees this, then, they'll laugh me out of the surgeon lounge. So it also keeps you accountable, lets you ask questions, lets you stay on your toes. So being in a group's a big deal, and I think that's really helpful. Nice comment from Busky NR. Dr. Donnelly's the best. So if anyone has any questions, I'm sure you can reach out to that comment right there, and they can tell you. I can't confirm or deny if you're my patient, but I have a lot of patients in here. Is cervical stenosis dangerous in the neck? It could be. It's just such a broad topic. Some people have it, and they can live their whole life and never need anything. Next question. I've seen the spine pain specialist for my fibromyalgia and don't know why. I'm not sure. Atticus, you keep talking about that cauda equina. I apologize. I really just can't give you any advice on that. It sounds like if you went to the hospital and I sent you home, maybe you should go talk to a different doctor. So I just don't know enough about it. I can't give you formal advice online for an ongoing condition, my good friend. From Anthony, would you recommend disc replacement for herniated disc? Probably not. I'd probably just do a microdiscectomy to get you in and get you out. Here's my thought. Thought on condylase. I don't know what that is, Bruce. If you direct message me, I can look into it. From Little Bird, is lying on the couch with your head propped up bad for your neck? No. If it feels good, it probably is okay. From Art, what are your thoughts on epidurals? Epidurals are great. There's so many keyboard warriors who will get out there and be like, oh, they're not FDA approved. Don't do them. They're terrible. Well, you're totally wrong. They aren't FDA approved. That part is true, but you'd be surprised by how many things out there you're doing or using that aren't FDA approved. Now, the reason they're not FDA approved is kind of a longer story just about the industry, getting high level of data, and then also having to fight with the insurance companies about some of that. But my own anecdotal experience, but more importantly, if you go to pubmed.gov, so pubmed.gov, and search effectiveness epidural steroids, there's legitimately thousands of publications out there, peer reviewed, that show how effective they are. And look, I don't do injections. This isn't me kind of fighting for my own thing. I do. I order them all the time, and goodness gracious, I would say, golly, of 80% of the patients I send out for injections definitely don't need surgery in the acute period because they work. So when people say they don't work, it's look, they didn't work for you, but they definitely work. I guess you say they don't work 100% of the time. So that's my thought on epidural steroids. I get a little mad when someone's out there telling other patients not to do it because, like, okay, so what should you do? Just live with pain or do surgery? Like, it's a terrible option for someone to be out there telling other people not to do something when they definitely work. From Raj, doctor, what causes disc degeneration? Why do some people get it? Does diet play a big role? Diet probably plays a big role. We just don't have a great understanding. There's a lot of anti-inflammatory diets that I've had different patients tell me they've taken and have really helped their back pain. Most of it's genetics. Most of it's wear and tear. Some of it's other factors, diabetes, smoking, little traumas. All right, guys, I got about 5 or 10 minutes left here, so I'll try to get to the questions. Again, appreciate the likes coming through. This is really helpful to kind of promote this to other people having stuff. I see a lot of people asking about telemedicines. Look, I don't want this to be a advertisement, but I do telemedicines all the time. You can just reach out to me. From Lou155, I do not treat that condition, so don't reach out to me. Can you catch a little bit about SMA3? Is that skeletal muscular atrophy? Is that what SMA3 is? SMA3, I don't know what that is. You have to direct message me so you can see. Upper cervical manipulation. No, I don't love that. Do you take CHAMP VA? I'm not sure. You can ask my office. SMA3, I don't 1,000% remember a ton of. It was something in med school and in orthopedic training I had to learn, but not an expert on that anymore. James Davis, that device you mentioned, I'm not going to mention it to everyone because I don't want to publicly talk bad about it, but I think that device is trash, and I think it is purely a billing thing that hospitals, surgery centers, and surgeons do. It's not, I just think it creates a big issue. Now, I do reserve the right to change my opinion later on that, maybe if I'd learn more about it. But there's actually decent studies that were published that showed that it kind of degenerates the end plates in the bone. So I'm not going to get on my high horse and tell everyone that it stinks, hence why I'm not saying the name of that device. But I don't know. The people that use it are all just people that use just rinky-dink products, as one of my buddies says. Is tramadol bad? Tramadol's good. You don't want to take it forever. Better than having spine surgery. From Charlie's asking about endoscopic being the gold standard. Maybe in another 10, 15 years. It's rapidly increasing here in America. The problem with it is it makes surgeries take longer, which if you're the patient, you're like, I don't care about that. Fair. They're more expensive. Again, if you're the patient, you're like, I don't care about that. That's insurance project. That's insurance problem. Fair. The next issue is it can't treat all the conditions that are out there. So this is part of it. From Ari saying 50% of fusions don't work. Why did people say that? It's just not a true statistic. So I don't know why, it's just something that people are going to say probably to the end of time, but it's just not a true thing. Like when you say don't work, also like, what does that mean? Like they break apart a day later, or you need another surgery 10 years later. Like, what does that even mean? I always kind of wonder when people say that. So not sure, but definitely not true. There's so many people that get extremely good. I had a knee corrective surgery. What can I expect from recovery? I'm not sure. I don't do knee surgery anymore. I did it in training, but don't do it anymore. Have you ever had someone operate on gun get MSSA? Maybe. Definitely had a patient. I've only had patients get infection. In terms of having MSSA versus other things, I just can't remember off the top of my head. So, spine infections do happen. I've had a good streak for a good while of nothing too infected or washed out in quite a while, actually, which is nice now that I think about it. But MSSA versus other organisms, I just can't remember off the top of my head. I usually have an infectious disease doctor at my hospital, and they help kind of manage that part too. Why would an ER doctor lie about a CT result? I don't know, but if you have caudal equination, MRI, not a CT. Do you think injections work in the spine? From Mickey Emerson. I do. Mickey, I just kind of went on a whole tangent about that. If you watch my YouTube of the same thing, that will kind of, you can, I don't know, go back probably around the 23-minute mark, and I should have talked about that. A couple other things. Have I heard of, and you said a certain name, have I heard of that surgeon? I have not heard of that surgeon. Bertolotti syndrome, Sheena, is pretty much when this bone here, this transverse process of L5 has over, I'm going to have to go immediately. Sorry, one of my kids is napping. I think he is about to wake up. He is. Okay, got to go. Sorry about that.